Good morning and welcome to Best of the Day from the 2013 meeting of the American Society of Hematology. Things are closing up this Tuesday morning at ASH, but there's still a lot of really interesting data to discuss. And one of the more interesting fields in hematologic malignancies in recent years have been the amazing changes in the management of multiple myeloma with a lot of new agents and still more new agents coming through the pipeline. So to talk about all of that with us this morning is Dr. Ken Anderson from the Dana-Farber Cancer Institute. Ken and I have sat down yearly for the last 10 years to talk about multiple myeloma. So welcome back to Best of the Day, Ken. Thanks so much for being here.
Thank you very much for having me. There really is an incredible track record of each year. It keeps getting better, Jim. So it's so appropriate that we get to meet.
And even though ASH had the multiple myeloma sessions set at the furthest end of the New Orleans Convention Center, a lot of people were still there to hear the data, and a lot of interesting data it was.
Yeah, I think there's palpable excitement in multiple myeloma, and it's wonderful. We've had clearly a change in the natural history. Patients are doing better than ever. And that's one message. And then the second is that we still have some new leads, and so the promise for even better outcome in the future.
Well, let's start with some of the Upfront trials, and one of the biggest was a plenary session presentation, and this was, I think, a really key phase 3 trial comparing what for many is standard therapy, especially in Europe, melphalan, and thalidomide, versus a doublet, a lot simpler, lenalidomide and dexamethasone. So this made the plenary session. This was the MM020 trial. So tell us a little bit about the design of the trial and how much data they had to present in the plenary session.
Yeah, so this is a very special event for those of us in myeloma. Every few years we get to be on the plenary session.
Right.
I was actually on the steering committee of this trial, so I know it intimately well. But in any event, it's the biggest trial ever done in multiple myeloma. It's 1,600 patients,
huge,
newly diagnosed with elderly patients. They were randomized, as you said, to lenalidomide, dexamethasone, given until progression in a continuous fashion. Lenalidomide, dexamethasone given for 72 weeks.
So 18 cycles.
18 cycles or 72 weeks, a fixed duration. And then melphalan, prednisone, thalidomide, similarly given for 72 weeks. So it's a triplet MPT versus a doublet Lendex given either fixed or continuous. And the reason the trial was on the plenary session, and the reason it's really a very important trial, as you mentioned, the lenalidomide dexamethasone till progression, Arm A, was increased extent and frequency of response, increased prolonged progression-free and overall survival. So on an efficacy endpoint, it was significantly better. But not only that, Jim, on the side effect side. So there's been a lot of concern over the years about secondary cancers. So that was looked at very carefully in this trial. And if you look at blood secondary cancers, which are really the major issue here.
MDS, AML.
Right, leukemia and MDS. As it turns out, Lendex continuously had a statistically significant lower incidence of secondary, especially hematologic malignancies. So we have winning on the efficacy and also on safety. So the message there is that it's really a twofold one, that Lendex is really a platform upon which many things have been and will continue to be added in the future. Already, proteasome inhibitors, for example, have been added to that, or antibodies. But that, in fact, it will really serve as the foundation. Second message, though, is one of continuous therapy, or if you will, maintaining therapy, and we'll talk about that a little bit later, but it's really a further argument for continuous or maintenance therapy as well. It's really important. In the United States, we already do use lenalidomide dex as just the doublet or as a platform. But it turns out in Europe and Asia and other places where it isn't approved, it isn't used. The melphalan-prednisone regimens are much more commonly used. So I think this particular first trial is a potential paradigm-changing trial, especially outside of the U.S.
Absolutely. And what does this say about the future for melphalan, at least as frontline therapy, not a part of high-dose regimen for a transplant, but what is going to be the role for melphalan versus a drug like cyclophosphamide that is less marrow toxic and easier to take in many ways?
So that is actually addressed directly by a study that was reported here by Antonio Palumbo, where he actually, and again, hundreds of patients, our European colleagues are really good at enrolling these large trials, but it was melphalan prednisone lenalidomide, Cytoxan prednisone lenalidomide, those two triplets, and with the two different alkylators, Jim, versus lenalidomide dexamethasone, just like in the first trial. And as in the first trial, the lenalidomide dexamethasone treated cohort of patients had a superior outcome. So I think what it's telling us is that the alkylator agent containing regimens are likely to be much less commonly used than this doublet, both in terms of efficacy but also side effect profile.
So do you think there's still going to be a role for the alkylating agents? I know the Cyborg-D regimen is used a lot by the Mayo Clinic group, and a number of people still use alkylators for patients who have already progressed on other agents.
Yeah, I think there will be. I think, we're very blessed in myeloma. We have immunomodulatory drugs, we have proteasome inhibitors as now our really two classes of agents, now new generations. But we have our old standbys to conventional agents of dexamethasone, DNA damaging agents such as alkylators or anthracyclines. And I don't think any of these studies are going to really have the impact that we're not going to use these drugs anymore. But I do think they're likely to have an impact in terms of how we use them. So I do think, especially in the elderly, newly diagnosed patients, assuming the costs allow this, which is a big assumption. But if that's the case, then I think what you're hearing from the large randomized trial, the first trial, 1,600 patients, and then the very large trial from Antonio Palumbo, and all of Italy was involved in that. I think what you're seeing is that a doublet, lenalidomide dexamethasone, was as good, in fact, better than the triplet.
So it is going to become at least a very important standard for the transplant ineligible patients.
Yes.
Well, besides MPT, the other regimen that has been used a lot in the older transplant ineligible patients is the VMP regimen from the VISTA trial with bortezomib, melphalan, and prednisone. And now, there is a new proteasome inhibitor on the market, also a parenterally administered drug, carfilzomib. And carfilzomib has been combined with melphalan and prednisone. And how, retrospectively, how do those two regimens compare? The old VMP with the new data using CMP, as it were.
So that is a registration trial that you're referring to, because the VMP, Velcade, melphalan, prednisone, actually is the reason that Velcade was approved for initial therapy in myeloma. So as you correctly point out, this is primarily a European trial, as you might imagine. The French are leading it, Philippe Moreau and his colleagues from the IFM. But this was an interim analysis, so we don't really have final results. But I think it is comparing very favorably. That is to say that carfilzomib, which is a more potent proteasome inhibitor, with melphalan and prednisone, is in fact achieving very high response rates, interim analysis, in the upfront elderly population. And I suspect that this CMP, carfilzomib, melphalan, prednisone versus Velcade melphalan prednisone trial will be a positive trial.
Very good. Well, and carfilzomib is an irreversible inhibitor of the proteasome as opposed to bortezomib, which can come off. So, I mean, now carfilzomib's been combined with MP, but one of the regimens that was really pioneered out of your group at Dana-Farber was the RVD regimen, where lenalidomide was combined with bortezomib and dexamethasone. That's been a very highly effective regimen in transplant-eligible patients. And now carfilzomib has been put into that RD regimen, so a CRD regimen replacing bortezomib. And there was data presented this week at ASH, just a phase 2 trial looking at that combination. And I know there are phase 3 evaluations ongoing. How does that triplet look thus far?
Yeah, so as you said, the carfilzomib is a more potent or a second generation irreversible. It's a different class. It's an epoxy ketone proteasome inhibitor. And although it's approved in the advanced relapse refractory, the registration trial is carfilzomib with lenalidomide dex in the relapse population, the so-called ASPIRE trial. That's fully accrued, and we're just waiting for that to read out next year or the year after. But I think what was reported here, as you said, is carfilzomib, lenalidomide, dexamethasone in 2 early settings. One, upfront active myeloma. And this is, both these studies have come from the National Cancer Institute. But the idea is, just as it was true with Velcade Rev-Dex, so it's true here with carfilzomib Rev-Dex, that the response rates are very high. For example, in active myeloma, with treatment, one gets response rates as high as 70 or 80%, including a high fraction of complete, near complete, and stringent responses. And then what's even more exciting is when we now look in some of these regimens, even for molecular or immunophenotypic complete responses, we're also getting high rates there as well. So it's looking very positive. The other thing I'll just quickly mention, also presented here, is that in an exploratory way, smoldering myeloma has actually been addressed with this same regimen. And as you would not be surprised to hear, that it's very active in that population as well. The one thing we need to remember, carfilzomib was approved at a dose of 27 milligram per meter squared. And many of these trials are attempting now to escalate the dose up to 36 or even 56 milligram per meter squared. And I think the appeal there is that the response may in fact be higher because there's a dose-response relationship. I think we need to be careful. I don't want to overstate it, but there's a small but nonetheless real cardiac signal which is being really carefully evaluated as to its mechanism, so that we can actually understand it and appropriately intervene so as to allow a better and a safer experience. But honestly,
don't escalate the doses unless it's part of a clinical trial.
I think that's a fair and a wise bit of advice, at least for now.
Very good. So, and then carfilzomib's also been combined with thalidomide as opposed to lenalidomide. Is there any advantage to that combination as opposed to the carfilzomib len-dex as far as adverse event profiles or cost?
Well, yeah, one of the adverse events is cost, right? So Peter Sonneveld, our colleague from the Netherlands, has, this is now in the transplant population, has done bortezomib, thalidomide, dexamethasone, 4 cycles induction, high-dose melphalan and stem cell transplant, often
VTD.
Yeah, often twice. So VTD as induction, and then VTD as consolidation, and with that consolidation, very, very deep responses can be achieved. So what he reported at this particular year's ASH is he has now done an analogous study with his cooperative group, his European network, myeloma network colleagues, of carfilzomib thalidomide dex both before for 4 cycles and after for 4 cycles as consolidation.
Consolidation, right?
And so I think the issue is, I think the response rates and even the immunophenotypic negative CR rates are very high. And you know, up until now, thalidomide is still been used very commonly in Europe. It's really, honestly, uncommonly used in the United States. On a medical level, it probably has less leukopenia or low counts effects than lenalidomide. And on a cost level, it's obviously much cheaper. So having said that, I think in terms of the extent of response and the lack of neuropathy and the lack of GI side effects or somnolence, sleepiness, all of those latter going with thalidomide, I think it's still way in favor of utilizing lenalidomide in these combinations if you can.
You mentioned, and this is just going to be an aside, but you mentioned smoldering myeloma, and there hasn't been much at this year's meeting about smoldering, but I know Vincent Rajkumar has been looking at the use of lenalidomide in the higher risk smoldering myeloma patients, and you mentioned the use of carfilzomib. Where do things stand with smoldering myeloma, and what are you all doing at Dana-Farber for those patients?
Yeah, so we are in the midst, we being the International Myeloma Working Group, of really redefining what is smoldering versus what is active myeloma. Smoldering myeloma was defined by my dear friend and mentor, Robert Kyle, in the New England Journal of Medicine in 1980. So it's okay now for us to try to revise it. And this revision was brought on by the paper that many of we all saw in the New England Journal from our Spanish friends, Jesus San Miguel and Maria V, as we call her, Dr. Mateos from Salamanca. But what they did, Jim, as you'll remember, is they used lenalidomide dex versus no therapy. Observation in high-risk myeloma, defined by the Spanish system, which is based on the amount of protein and, honestly, the immunophenotype showing that the majority of the marrow plasma cells are indeed myeloma cells. Or they used the Mayo Clinic system, which is high risk. It can be based on the amount of protein, the bone marrow plasmacytosis, and the kappa lambda free light chain ratio. In any event, their paper was published in the New England Journal of Medicine because lenalidomide dexamethasone not only delayed progression, but actually was a progression-free and overall survival advantage. Now that trial, as I like to call it, is paradigm changing, but not practice changing, because it answers your question directly. It brought us in kind of an emergent fashion last June to meet as an International Myeloma Working Group and redefine who really has active myeloma in 2013.
So the CRAB criteria may be changing.
Absolutely. The CRAB criterion is really, has already changed. So hypercalcemia, renal disease, anemia, and bone disease is the foundation. But to that has been added recurrent infections, neuropathy, and hyperviscosity. So that's already done. But what I think is happening, and I'll just share, for example, in order to define whether a newly diagnosed patient has actually smoldering or ends up being high risk or active disease, for example, parameters such as the height of the free kappa lambda light chain, so over 100 has been, looks like it predicts for active progression. The bone imaging studies, other than the plain rentgenograms or the bone survey, we need, and we are doing this now, incorporating MRI or PET-CT into things. And then the amount of bone marrow plasma cells. It turns out that in studies, 60% or more plasma cells in the marrow now predicts no longer smoldering, somebody who's active. This isn't totally defined, but I mention it because I believe strongly we'll have many more patients eligible for therapy than ever before. In other words, the category of smoldering myeloma will be smaller, and the category of active myeloma will be larger. Right now we're in a period of flux that will be defined very soon. And it's important because earlier treatments, very effective treatments, often oral, are being utilized. Some novel therapies such as antibodies, elotuzumab, the new CD38 antibodies for sure will be used in smoldering. We're using, you had asked before, we're actually in many trials, but for example, we're vaccinating patients with smoldering myeloma and generating an immune response in the ultimate goal of delaying or even preventing their progression to active disease. So it's being redefined, it's totally appropriate, but it makes the current studies a little bit difficult to interpret. So this carfilzomib, lenalidomide, dex in high-risk myeloma, smoldering myeloma,
Smoldering, right.
it's difficult because the Spanish system that I described before and the Mayo Clinic system that I described before, they are both being used, but they only agree about 20% of the time.
So I think, as you say, this really is paradigm changing. May not be practice changing yet, but soon.
I think so.
Soon. All right. Well, we'll end this segment and come back in a few minutes and talk about the whole maintenance or continuation treatment and the controversy that has been discussed here at the meeting. So thanks so much for watching this segment on Upfront Therapy. We'll be back with you in a minute.